Good morning, good afternoon, everyone. Welcome to our session on perioperative hemostasis and transfusion management in older adults. I'm Carolina Haylock-Lohr, President-elect of the WFSA and member of the WFSA Patient Blood Management Steering Group. I am based in Honduras. I am an anesthesiologist, critical care medicine, and interventional pain physician, and I am delighted to join you, all of you right here. So thank you very much to be here. And I am also, it's also a privilege for me to co-moderate this session with Dr. Freddy Ariza from Colombia, who co-leads the WFSA p-PBM, Patient Blood Management Project, alongside Dr. Filipescu. Dear colleagues, today this is the agenda and some housekeeping information. Today, the Q&A session will be can be submitted in the Q&A box, but also it will be at the end of the session if you want to submit any question, please do it at the Q&A box. The translation, this webinar use Zoom AI translation. It's a feature for live subtitles. It right there in the closed caption, you can click on your preferred language in the settings. Certificates of participation will be issued within 15 business days after the webinar, and to qualify, participant must attend for at least 60 minutes. The recording will be published on YouTube soon, so a link will be shared with you by email. Dr. Freddy.
Oh, thank you, Dr. Carolina, and thank you all for being here. It's my pleasure to introduce our first speaker, Dr. Professor Donat Span. He is Professor Emeritus of Anesthesiology at the University of Zurich and former chairman of the Institute of Anesthesiology at the University Hospital of Zurich. Founder and president of the Swiss Foundation of Anesthesia Resident Anesthesiology Research and CEO of the Swiss p-PBM Consulting Group. Donat is an incredible author. He has authored over 40-60 publications and delivered more than 850 embedded lectures. Thank you, Donat, for being here, and the floor is yours.
Thank you so much, Freddy. It's actually it's my honor to be here, and a warm welcome to everybody who listens now. I'm happy that I can present the topic of age-related changes in hemostasis, implications for perioperative bleeding and transfusion risks. Okay, now we have a technical problem in that I can, now, okay. So these are my conflicts of interests. I do consult companies. I am the co-chair of the European Trauma Treatment Guidelines. I consult universities and professional societies. And I receive honoraria or travel support for lecturing from different companies and also from foundations and associations. So the fibrinogen changes over lifetime, you can see here, starting with the age of 25 to 85 years to the right. And you can see here that it steadily goes up. So this is a population study. And on the right side, you see trauma patients where the fibrinogen is lower in the lower range of age, namely up to 64. And it's then higher in the higher range in the patients with an age of over 65. And this at the very similar ISS. So fibrinogen definitively goes up with age. Platelet counts, well, platelets first decreased down down up to an age of about, let's say, 20 years. And then they are stable about to 60, 64. And in this study here, big population study, they tend to go down. But this study already ends at 75. And on the right side, you find platelet numbers from patients in the age of 60 to 100, and you see they are more or less stable. So platelets, I would say, don't change much at aged adults. These are ROTEM changes with age in patients undergoing cardiac surgery. And you see the amplitudes, they tend to go up with age. Also in MCF for the fibrinogen function. And the times CT in the XTEM, for example, tend to go down. So this means that when you look at the ROTEM, you think that the patients at higher age may have a more competent coagulation, more towards hypercoagulability, or you may conclude they have more coagulation reserve during bleeding. When is this really interesting or important? You know, these are operations, major trauma, cardiac surgery, or any urgent surgery. With regards to the trauma treatment guidelines or trauma treatment, I refer to the European guidelines on the management of major bleeding and coagulopathy. We have now 6 published versions. They were cited more than 4,000 times and accessed more than 1 million times. And they are important because trauma is an important and increasing event in elderly adults. This is a study from England and Wales, where you see that in the age group of 50 to 100 years, in the latest years, their trauma incident increases. And it is also this group of patients that is more and more anticoagulated, and the total number of anticoagulation doses used in Switzerland goes up every year. And the percentage of patients treated with a 10A inhibitor is now about 85%. This may be different in different countries, but in many countries, the newer anticoagulants are more and more used. And of course, if you see a trauma patient, an elderly trauma patient, the first question is the patient anticoagulated? And in this article in the anesthesiology quite a number of years ago, we came up with a very simple scheme, really super simple. So you need only to measure prothrombin time, anti-10A activity, and thrombin time. And when the prothrombin time is elevated, of course, it's vitamin K antagonist. If there is any anti-10A activity, it's 10A inhibitor in the circulation. And if the thrombin time is elevated or usually non-measurable, it's dabigatran. That's really so simple. So the European trauma treatment guidelines, they clearly promote goal-directed strategy guided by standard laboratory coagulation or viscoelastic measurements like ROTEM or TEG. In terms of vitamin K, dependent oral anticoagulants, we say we need to treat that after trauma with PCC and 5 to 10 milligrams vitamin K IV. In patients where we suspect anti-10A antagonists and the bleeding is quite heavy, life-threatening, then we say that we need to measure plasma concentration and then to antagonize, if available, with andexanet alpha in different dosing regimens depending on the time since last ingestion. Or and this is very important, we can also use prothrombin complex concentrate. And which one is really better? I'm convinced nobody knows today. In the dabigatran patients, of course, idarucizumab is the way to go. There is no other thing. Now, in urgent surgery, the initial coagulation assessment is the same. PT, anti-TNA, thrombin time. You remember this is necessary to find out whether the patient is anticoagulated, yes or no. Then, of course, ROTEM or TEG, because you want to have a baseline. You use these tests then also during surgery, platelet count and fibrinogen level. You start surgery, and then you continue coagulation monitoring with ROTEM and TEG. Treat the patient according to a coagulation algorithm. Administer tranexamic acid in urgent surgery, 1 gram. And the question is, do you need an initial coagulation correction? In patients with dabigatran, absolutely clear. You give either rucizumab, 5 grams IV and tranexamic acid, vitamin K inhibitors, prothrombin complex concentrate, and vitamin K. And in patients with 10A inhibitors, well, here the situation is not so clear. We need to distinguish between cardiac surgery and general surgery. In cardiac surgery, you can use cytosorb at the cardiopulmonary bypass that eliminates the 10A inhibitors. And in general surgery, we in Zurich follow a watch and wait strategy, because we recently published this study, a retrospective study in 32 patients with plasma levels, anti-TNA plasma levels far higher than 100 nanograms per ml prior to urgent surgery. And of course, those that received some antagonists already we have excluded. Also those who had unspecific treatment with PCC. And then all the patients were managed based on a ROTEM and lab-based coagulation algorithm using this watch and wait strategy. And the outcome was the RBC loss intra and up to 3 post-operative days. And you can see here on the left side, first of all, the median factor Xa level at start of surgery with 240 nanograms per ml was really high, but the median RBC loss was not. So during surgery, 49 mLs, and so and then first and up to third cumulative 250 mLs RBC loss. And you see there is no correlation between the 10A inhibitor plasma concentration and the RBC loss here depicted intraoperatively. No correlation whatsoever. And here on the right side, you can see the overview of stable and labile blood products. So andexanet alpha was not used, and 4-factor concentrate, prothrombin complex in only 1 patient. And the rest was also hardly ever used. So when you go by a restrictive coagulation management, but individualized and goal-directed, you can follow in these patients a watch and wait strategy and only intervene when it's really necessary. And this was the coagulation algorithm that we used. So there were some general measures. We tried to maintain normothermia, of course, normal calcium, normal acid-base status, hematocrit at least around 21, maybe 24, permissive hypotension to start with, as long as there is some bleeding, surgical bleeding. If the FibTem in the ROTEM indicating low fibrinogen levels is below 7, this is really low, then we gave fibrinogen concentrate. After 6 grams, we added also some factor 13, but that's relatively rare, but that's important not to forget the factor 13. If we detect fibrinolysis, we give additional tranexamic acid. If the factor 13 activity is below 60%, we give factor 13 concentrate. And if we have ROTEM signs of platelet, low platelet counts, then of course we give platelet concentrate. And if the INR is more than 2.3, or we use a 4-factor prothrombin complex concentrate. And only if factor 5 activity is below 25, we give FFP. And this actually, this algorithm was used in a prior study from Philipp Stein that we published in Anesthesia in trauma patients, where we compared the outcome, transfusion and otherwise, in a period 1 before we use this coagulation algorithm with the period 2 in green here, where we use this very algorithm. And you can see here packed red blood cells decreased in the first 24 hours from 5 to 2, FFP from 3 to 1, platelet did not change, and in terms of clinical outcomes, ICU length of stay decreased, ventilatory support decreased, and I'm sure this is because we did not give FFP, and even in-hospital mortality could be decreased. A similar successful study was done in cardiac surgery in Frankfurt. They compared 2 coagulation algorithms, one based on conventional aspects, the other one on ROTEM, and they found that in the ROTEM group, they could decrease RBCs from 5 to 3, FFP from 5 to 0, and then they did give about the same amount of fibrinogen. Factor 7A, they did decrease from 24 to 2. And very important, by doing this, or by following this ROTEM-based and coagulation factor-based algorithm, they could save per patient about 1,500 euros per patient. So this is not more expensive, but is much cheaper, and it increased survival in those who were treated according to this ROTEM-based algorithm. The conclusions thus are that coagulation system of the elderly and the young are very similar. Fibrinogen concentration is increasing with age. Platelet count is approximately stable in the age range of 60 to 100 years. ROTEM tech parameters show mild hypercoagulability, amplitudes goes up and times go down. Variability between patients, however, is huge. Therefore, for an individualized goal-directed treatment, please measure PT anti-10A activity and thrombin time initially, platelet count, fibrinogen, ROTEM tech repeatedly. Use algorithm to detect and treat anticoagulation, monitor coagulation during surgery, and treat coagulation problems in an individualized, goal-directed manner. Thank you so much for your attention.
Thank you, Professor Spand, for sharing that, well, older adults have different changes in platelet functions and also some coagulation factors. And these changes can increase the risk of both bleeding and thrombosis during and after surgery, as you just shared. Understanding these changes is crucial for anticipating potential complications. So transfusion also can be life-saving, but they also come with potential risk, especially in older adults. Let's delve into some specific examples and recent research findings on this topic with Professor Afaq Misri. She's graduated in the Hassam Second University of Casablanca, Morocco, specialist in anesthesiologist and intensive care. She is president of the Society of Morocco of Anesthesia Reference Committee, president of the Hemostasis Club in the same society in SMAR, and member of the Implementation Committee of French-Speaking Group for Enhanced Rehabilitation After Surgery, GRACE. She's author of several publications and conferences. Dr. Nesri, hand over to you.
Thank you. Thank you very much, Dr. Carolina, for this kind invitation and to participate in this really webinar with the great speaker and the great lead in the p-PBM. Thank you. First, good morning, everyone. I want to introduce this presentation. That's the prevalence of anemia in older adult. The prevalence is increased in late life, in our late life, and as we can see, after 60 and 70 years old, the anemia increase in both men and women. In the early life, the women have more anemia than men, but after 60 years old, it's the men we can see, and men have more anemia than women, and it is increasing with the aging. In the older, we can see they have many comorbidities like cardiac, kidney, and pulmonary disease, and that all this we can see that with anemia in this elderly patient, the complication more higher, and we can have with anemia the alteration of cognitive function, also iatrogenic injury, more hospitalization, less quality of life, more mortality, more frailty, and less mobility. And with this all complication, the anemia is a real issue and in the elderly patient. Excuse me. Why we assess anemia in perioperative? Why we should assess this anemia in perioperative? Anemia in elderly patient also they have already anemia because they have many inflammatory diseases. They have acute chronic kidney failure. They can have inflammation and many infection and iron deficiencies, vitamin B12. And in perioperative anemia, this anemia can increase and can have a real problem and a real issue in this period of the perioperative. And all this issue can make us to transfuse blood transfusion, but it's the good idea. Oh, excuse me. In this figure, we can see that with if the hemoglobin on perioperative is lower, the risk for death within 30 days is higher. And so we have to have really the good level of hemoglobin before surgery, because it's the outcome of the patient, and the death within 30 days can really be related. And so we have to have the p-PBM protocol to can prevent these days or this outcome, this complication outcome. And in the p-PBM, as we know, we have 3 pillars to have perioperative management, like to prevent the iron deficiency, nutrition, coagulation study of the patient, pharmacological review, and intraoperative management to have mini invasive surgery and post-operative. And in the post-operative, we can individualize the threshold of hemoglobin, for example, before to transfuse, and verify blood loss immediately on post-operative. If we can, before to speak about the usual complication of transfusion in the elderly patient, I want to just have this point about inflammatory response and immunosuppression and cancer recurrence after perioperative blood transfusion. If we can ask, is the transfusion have a role in the recurrence of cancer in perioperative? In this publication in 2013, we can say that this subject and this discussion was started in the 1980s, and many publication about this relationship between inflammatory immunosuppression, transfusion caused by transfusion, and cancer recurrence. But we can have really we can have the certitude we have the relationship with transfusion and cancer recurrence. But we have many publication and many trials about this issue and this point, and we have to have this point in our mind when we transfuse our patient. It's not really we are not sure for this, but we have many trial like this. They have the patient with endometrial cancer and ovarian cancer. In ovarian cancer, we don't have the relationship between bad outcomes and transfusion. But in endometrial cancer, this perioperative RBC transfusion worsen prognosis in endometrial cancer, but not in ovarian cancer. Therefore, a restrictive transfusion strategy is recommended in endometrial cancer. And so we can really be careful to transfuse the patient with cancer, because the probability they have recurrence and they have complication and worse outcome with this transfusion can be a real issue and can be realistic. And if we continue with the risk and expected benefit, we have expected benefit with the transfusion to improve tissue oxygenation, prevention of cardiac decompensation, better tolerance to surgery anesthesia, good impact on mortality and morbidity. That is the question, but we have more risk than TACO and TRALI, and we can we have all the anesthesiologists know this complication. Immunological transfusion can reaction. In the older patient, this immunological transfusion is more than in the younger, and increased risk of hospital-acquired infection. They have immunosuppression, and the patient can have more infection on perioperative. Overtransfusion can provoke more morbidity and mortality. And with all this, the evidence that restrictive strategy can be safe. And we have many publications in this direction. We have many meta-analyses like this about cardiac, vascular, oncologic, and burn orthopedic surgery. And conclude that intraoperative restrictive transfusion strategy decrease perioperative transfusion without added post-operative morbidity and mortality in 12 trials, 2 trials worth outcome. And so we can see that if we transfuse less our patient, more higher the less complication we can have. And if we see, we have here many publications in cardiac surgery, in emergency surgery about open abdominal surgery, and in hip surgery, and in all these trials, the transfusion when we transfuse the patient, we have more acute and mortality rate. And for example, in hip surgery, in intraoperative blood transfusion, increase in morbidity and mortality within 60 days, acute and if as we can see, we should be careful when we transfuse our patient, and the restrictive strategy can be more safe with our patient. Maybe with the patient with the cardiac infarction, the liberal strategy can be more benefit. But in this trial, in restrictive or liberal transfusion strategy in myocardial infarction and anemia, published in New England in 2023, they have two groups with restrictive strategy and transfusion and liberal strategy. It's not on perioperative, but in the patient with infarction myocardial, and we can see there is not really the difference in the outcome before the two groups. And restrictive strategies, even in the patient with the myocardial problem, can be safe. It can be safe as the liberal strategy. So limited availability of blood resource and potential complication with transfusion, we conclude that restrictive strategy is recommended. But the problem is the hemoglobin threshold, 7 or 8 grams. We have not guidance with the guideline, and the guidelines they recommended the restrictive strategy, but we don't have the number of hemoglobin threshold. So in this guideline of patient management in adult cardiac surgery in collaboration with BC, it's the AST, and in 2024, the main point in this recommendation that we should individualized assessment with the patient. We can assess the hemodynamic, the biological, and the laboratory values, and also the hemodynamic status of the patient. So we can have just one number for all the patient. It's not like this. We can absolutely, we should absolutely individualize assessment with patient, and every patient can have own decision. And we can see one size fits all, not in elderly patient. And the solution is the patient blood management. Of course, we can prepare our patient before the surgery. We can minimize the loss. We can optimize the hemoglobin, iron, B12, and OPO. And in perioperative, minimize loss, bleeding, with minimally invasive surgery, topical hemostasis, and tranexamic acid, who has really good values and sometimes cell-savers, but it depends the techniques and the cost in the perioperative. And on post-operative, we should optimize tolerance, restrictive transfusion strategy. It's the safe, but it's not. It's depend of the doctor. It's depend of the anesthesiologist and the surgeon. It's decision of the team, and we should individualize this decision, and it's depend on the tolerance of the patient and of the anemia. Home message, the high prevalence of anemia alone does not justify routine transfusion. It's really that we have higher prevalence anemia in the patient, and sometimes we are in trauma, surgery, or in the emergencies, surgery, but we can assess this anemia, and we can see if we can added some correction of this hemoglobin level before surgery. Transfusion risk exists and must be considered. We should have more aware by these risks, and don't have the facility and to transfuse the patient. The more easier way is to transfuse the patient, but the outcome, it's not really good, and the patient have to pay very cost this decision to transfuse him. Restrictive strategies are safe and evidence-based. As we have seen, we have many trials that demonstrate that we can have restrictive strategy, and it's not it's safe for our patient. Always individualize decision and threshold. It's the one of principle of the perioperative medicine. We should individualize decision, and we can have an idea about the status of our patient, clinician status, and tolerance. It's just about number of hemoglobin, but it's about all the patient. Thank you.
Thank you very much, Afak, for those insightful reflections. And all the patient, the transfusion decision should be guided, as you said, not just by hemoglobin numbers, but also by clinical status and expected benefits versus risk, and some really like individualized. Next, let's examine how we can prevent the need for transfusion by optimizing red cell mass before surgery. So I have the privilege to give the floor to Dr. Freddy Ariza. He's an anesthesiologist at Fundación Valle de Lili, affiliated with the ICESI University and Universidad del Valle in Colombia. He is currently serving as board member of the Colombian Anesthesia Society, SCARE, and a faculty board of the ABC TEMS, that's Advanced Bleeding Control in Trauma and Major Surgery. Okay, Dr. Freddy Ariza, hand over to you.
Oh, thank you, Dr. Carolina. I'm gonna share my screen. It's seeing well. Okay. It's a pleasure to be here, Carolina and Janet and Afak, for exploring a topic that especially attracts my attention, and it's becoming increasingly critical in preoperative care, optimizing red cell mass before surgery in the older adults. As we know, this population is especially vulnerable to anemia and its consequences preoperative anemia is not only common, but also a strong predictor of poor surgical outcomes, as Fag and Donat presented. Longer hospital stays, higher transfusion rates, and even increased mortality. In these sessions, we'll walk through the evidence, diagnostic strategies, and practical interventions we can implement as part of PBM in the elderly patients. This is my conflicts of interest. And I would like to show in this graph that offers a powerful visual of how anemia affects different age groups with significant implications for preoperative planning in the elderly. While anemia is notably more prevalent in women when they are younger, especially after age 50, what's particularly important for us is the trend beyond age 60. It's very interesting that prevalence rates rise steadily with age, and by 85 and older, men actually surpasses women in anemia rate, highlighting the vulnerability of elderly males who may have been overlooked in screen efforts. In 2019, the global point prevalence of anemia that was attributable to dietary iron deficiency was higher than all other causes in all age groups, except in the more than 95 age group. The peak of anemia found in the 1 to 4 age group then generally decrease up to the 20 to 29 age group, then broadly increased up to the 85 to 90 age group before decreasing over the remaining age groups. The number of prevalent cases attributable to dietary iron deficiency and hemoglobinopathies and hemolytic anemias accounted for the largest proportion in all age groups. The global point prevalence attributable to chronic kidney disease started to increase at the 50 to 54 age group and reached its peak in the oldest age group. What we have to know is that by 2050, individuals over 60 will make up nearly 1 in 6 people globally. These age groups is already accounting for 40 to 50% of all surgical procedures. Importantly, up to 40% of patients over 70 are anemic at the time of surgery. These patients face unique vulnerabilities, reduced physiological reserve, frequent underdiagnosis of anemia, polypharmacy, and increased bleeding risk from anticoagulants. The gastrointestinal tract that you see in the center of this slide plays a central role in anemia pathogenesis. Common causes include malnutrition, upper and lower GI bleeding from ulcers and malignancies, and malabsorption due to infectious inflammations and medications. As emphasized in the yellow box, the increased multimorbidity and frailty seen in older adults complicates perioperative care and heightens their vulnerability to anemia, transfusion, related risk, and impaired functional recovery. Without early identification and treatment, these factors contribute to longer hospital stays, increased morbidity, and worse postoperative outcomes. But let's review a few of pathophysiology of iron deficiency in aging. Let me walk you through this slide, which summarizes the complex pathophysiology of iron deficiency anemia in older adults. A key mechanism associated with aging called inflammation, a chronic low-grade inflammation that drives overproduction of hepcidin, the hormone that blocks iron absorption and sequesters iron in macrophages and hepatocytes, resulting in functional iron deficiency. At the same time, older adults often show a blunted erythropoietin response. The limiting red cells production even when anemia is present. IDA is multifactorial, as you've seen, often linked to malnutrition, chronic disease, polypharmacy, and acute GI bleeding. To make things worse, during acute illness or hospitalization, there is an upregulation of inflammatory cytokines like interleukin-6, which further stimulate hepcidin production, exacerbating anemia. All of these mechanisms reinforce the idea that IDA in the elderly is not just a laboratory finding. It reflects a deeper, multifaceted management strategies, especially in the perioperative period. Consequently, I would like to show a significant increase in adverse outcomes. It's not difficult to predict that happens with preoperative anemic elderly patients. I have tried to summarize evidence here for you. The data consistently show a significant increase in adverse outcomes across the board. These patients face 2 to 3 times higher risk of 30 days mortality, which make the strongest indicators of the clinical importance of preoperative anemia. Cardiac complication increase. In orthopedic surgery, the risk of postoperative delirium is doubled in anemic patients, complicated recovery. Transfusion rates are 4 times higher. Anyway, moreover, readmission rates within 30 days are 20 to 30 higher in anemic patients, often due to unresolved or worsened functional and clinical issues. This is a very simple algorithm that was presented in a recent paper for showing us that anemia in elderly may be approached very easy by measuring or assessing ferritin levels. If ferritin levels is under 100 micrograms per liter, you can start to approach this case as an iron deficiency anemia or an iron deficiency anemia of chronic disease. But by the other side, if we have a ferritin more than 100 micrograms per liters in a patient, in an anemic elderly patient, we need to start to think in anemia of inflammation or chronic disease. It makes the topic or the point of the treatment, and we know that iron replacement is the center, the cornerstone of preoperative anemia. It's very important to particularly via the intravenous route. And while oral iron may be considered if surgery is more than 8 weeks away, its poor effectiveness limits its use. Intravenous iron is preferred as it significantly improves response to erythropoiesis stimulating agents, enhances quality of life, reduces transfusion needs, and lowers required stimulating erythropoiesis stimulating agents doses, all without increasing the risk of infections or cardiovascular events. This is very important to consider in elderly patients. It should not be given to patients with active infection, obviously, and must be timed appropriately around chemotherapy before or after, not during the chemotherapy. No evidence linked IV iron to tumor progression, reinforcing its safety and value in preoperative care. Finally, nutritional deficiencies in the elderly are relatively straightforward to treat, but anemia associated with chronic disease or chronic kidney disease poses therapeutic challenge, particularly due to elevated hepcidin levels that impair treatment response. Traditional use of erythropoiesis stimulating agents is limited by safety concerns and reduced efficacy. Erythropoiesis stimulating agents have traditionally been used in chronic kidney disease and end-stage renal disease, improving patients' quality of life, physical performance, and reducing hospitalizations and mortality risk. Novel therapy strategies such as anti-epsilin antibodies, inhibitors of some kinases related to enhance epsilin function, and activin ligand traps are under investigation and may offer promising alternatives. Vitamin D has also emerged as a potential modulator of treatment in this elderly patient, because high doses of vitamin D can reduce epsilin levels. For the multifactorial treatment of these patients, of this subpopulation, is very important to the importance of assessing functional fitness before surgery, especially in older and high-risk patients. Functional status is a stronger predictor of outcomes than age, and low fitness is linked to more complication, longer hospital stays, and higher mortality. Tools like gait speed, grip strength, it can help identify patients who may benefit from rehabilitation. So my take-home messages are that anemia in older adults is very common, underdiagnosed, and linked to poorer preoperative outcomes, including higher mortality. Iron deficiency remains the leading cause of anemia in the elderly, and preoperative detection and correction of anemia must be a priority in this subpopulation. Oral iron is rarely effective in the short preoperative window and should be reserved only when surgery is delayed more than 8 weeks. Emerging therapies and pathways such as epsilin antagonists are promising but not yet standards. Current best practices is still centered in iron replacement, SIS, and rehabilitation. We have a structured multidisciplinary p-PBM strategy that includes all the professionals around the elderly patients to ensure the best outcomes and good results. Thank you so much.
Thank you so much, Dr. Freddy. So strategies like diagnosing and treating preoperative anemia, administering IV iron or erythropoiesis stimulating agents, and ensuring good nutrition are proven ways to reduce transfusion. Would you agree, Dr. Freddy?
Absolutely, Dr. Carolina. It's very important that a multi-professional approach be ensured in this patient that are at a high risk of many complications. I would like to tell you that the elderly patient needs a very structured p-PBM approaching, and I think that Donat and EFAC can complement my statement. What do you think?
Yes, absolutely. So we will share a little more about this. We would like to open the floor for any questions you might have. Dr. Freddy, would you like to start, please?
Oh, of course. My first question is for Dr. Donat. Donat, we have currently or usually many questions about the safe use of medication as tranexamic acid. Would you like to tell us what's the best recommendation for the use of these non-transfusional strategies for reducing bleeding in the elderly patients?
Yes, I would say if a patient has not has not happened to have a huge thrombotic event or a pulmonary embolism weeks prior to surgery, I would give tranexamic acid to all elderly patients for all major operations. And remember, there are hundreds, at least 500 meta-analyses of the benefit and potential harm of giving tranexamic acid to patients undergoing major surgery, and all, without any exception, come to the conclusion they are highly efficacious and there is no side effects.
Absolutely, Donat. Donat, I would like you to expand a little more about a very common bad outcome presented during the perioperative, that it's hypothermia, like a low-cost strategy to reduce bleeding. And elderly patients, as we know, has a high risk of this type of event.
Yes, I mean, elderly patients are more frequent, and if so, lose more body temperature during surgery if we are not actively warming them. And as long as we are talking about a elective surgery, we are to warm them ideally even prior to anesthesia induction, because anesthesia induction creates the biggest temperature drop in patients, particularly in the elderly patient. So pre-warming is the term that what we really should do. Actually accepting hypothermia, or even let the temperature actively go down, I think is not a good idea in any case.
Thank you, Dr. Span.
Okay, I have several questions in the Q&A box for Dr. Afak. I will make one question out of three that it says about the transfusion, the use of crystalloids, and other colleague is asking about colloids in older patients. What is your opinion?
Yeah, thank you, Carolina. Yes, I think about crystalloid, yes, we can use the crystalloid in the older patient, and it's we can have this hemodilution and not to transfuse the patient. For the colloid, we can be more aware because the kidney failure, they can have some kidney failure, but the crystalloid or the ringer lactate we can use for the patient in the patient without problem. If we have a long time of operative, and sometimes we can have acidosis and hyperkalemia acidosis with crystalloid, but we can use it and be aware about this complication and manage it with respiratory and even we have acidosis with crystalloid, it will be solved in post-operative. But it's not the transfusion, it's not the RBC, the solution for the patient, but we can have 7 hemoglobin or 8 hemoglobin in the patient, especially those they don't have the cardiac issue, and they can be safe with this level of hemoglobin.
Thank you, Dr. Afak. That gives me the right words to go to Dr. Freddy with that example you just did about a patient with 7-8 of hemoglobin. And when will you decide, Dr. Freddy, if given IV iron or go to a transfusion with this patient that you have 7 to 8 grams of hemoglobin?
It's a very interesting question, because I think that elderly patient, it's a subpopulation where definitely as the same size is not for all. You have to always point to your parameters of hemodynamic and systemic repercussion. If you have a patient between 7 and 8 grams per deciliter, but you are in front of hemodynamic instability, and you have a setting of metabolic acidosis increasing with time, you need to start to think to optimize, initially to optimize the cardiopulmonary response. But if you can't afford with this, and you cannot maintain the hemodynamic instability, I think that transfusion may be needed in these patients. The elderly subpopulation has a very small grade of response or tolerance to many preoperative stress. So I think that it's important to personalize every case and build your own decision for the correct patient.
Thank you very much. I think Afak had her hand up.
Yes. It's for Freddy that in the guideline you say that for iron oral iron we can give it to the patient if we have more than 8 weeks surgery. But just one question, you know that in the elderly patient they have many inflammation, they have many disease, and absorption for the iron it's really really very small, and I think that it's very hard to correct the level for iron just by oral way.
Yes, Afak, you are right. In fact, the oral iron is not recommended for the common use in the preoperative. At least you are with your patient in the postoperative when you are discharging your elderly patient for going on and for going home and reestablish its blood without urgency. But in the preoperative, IV iron is the standard of practice, as all the studies and the evidence shows that IV iron reflects the best phase of improving all the markers of perioperative good outcomes, quality of life, less days in hospitalization, improvement of cardiopulmonary response, and it's no doubt that IV iron is the standard of the day.
Thank you.
This links also to this other question that goes to the three of you. Does the surgeon allow or agree for IV iron therapy preoperative law, or it's the physician who decides, or the anesthesiology itself? Who decides?
Well, for me, it's clear it's the patient's physiology or pathophysiology that decides. I mean, it's clear if there is a clear iron deficiency, it needs to be treated. If it's a clear iron deficiency anemia, that needs to be treated. If it's another type of anemia, and this is particularly in the elderly frequent, that it's anemia of chronic inflammation, then it needs to be treated, but differently, namely with EPO and not only with IV iron. But I don't see any way how a surgeon could say, I do not agree that my patient gets IV iron if he has an iron deficiency.
Any other
Absolutely.
comment about it? Yes, all agree. Okay, we have a question right here for Dr. Span. What is your opinion on the routine use of tranexamic acid for elective and emergency C-section?
C-section in the elderly.
Just well, at this time, there are many cases, special cases. So let's have the positive way of this question. Yeah.
Yeah, you can use it. Yeah, sure. But the efficacy, that's not the most efficacious situation where you want to use tranexamic acid. Sure, if there is some major postpartum bleeding, then of course that's a cornerstone that needs to be given as soon as possible and at high doses. But routine, I'm not so sure.
Any other want to add?
Yes, we don't usually to put or administer tranexamic acid as a prophylactic in C-sections. Yes.
We don't use it also. You don't use it as tranexamic. It's not systematically. If we have a hemorrhage postpartum, yes, but not this section.
It's very important, in fact, to take care for not overuse and expand the real benefits of a drug, because bad use of very good medications affects their safety concerns worldwide. So please try to make the best use for these medications, because if you administer to a high risk of thrombotic events patients, you can obtain a bad result, and this is not just with your patient. Please think before use these strategies.
Thank you very much. What is I think it's for Dr. Span also, what is the turnover times for TEG and ROTEM reports at your center?
Well, at the centers that use it very routinely as ours, we have the machines in the OR. And so us anesthesiologists, we do the tests. The newer versions are automatic machines for ROTEM and TEG, and they are not more difficult to use than a blood gas analyzer. And the developing curves are immediately transmitted to the OR, where the anesthesiologist on site sees how the curves develop. And after 10 minutes, it's clear what's going on.
Thank you very much. Okay, for this, I think we have time for one last comment about, it was to Dr. Afaq, related to what is the transfusion trigger of packed cell in a known patient with a myocardial ischemia?
It's in older adults, we generally aim for restrictive transfusion strategy whenever possible. But for that, it's for stable, no cardiac surgery patient. But for the patient who have cardiac disease, it's depend on this patient. They are stable or not stable, and their tolerance of in anemia. If this patient can have, they have stable clinically and they have a good hemodynamic status, we can go between 8 and 10 hemoglobin. But if they have unstable, and we are afraid about infarction cardiac, we can go maximum to 10 of hemoglobin. But it's depend of the patient, and as we said before, it's really individualized strategy for each patient. And even in the recommendation, we don't have one number, and it's about 7 and 8, but it's really about the status of the patient. And we need to assess the anemia and the situation of our patient to decide what the level we can target with the transfusion or not transfusion.
Thank you, Dr. Afak. Any other want to add to that comment? Okay, there are some comments also related to the C-section. That in emergency situations, also to assess, as Dr. Afak said, individualize each case. But if you're in an emergency, of course, you can use tranexamic acid. Some others say it until now it's not recommended. So that means it's a very good point, to highlight, because that means that we're sometimes not absolutely sure what to do. In some cases, that means that when you're in an emergency, you must tailor or contextualize what's going on and specific for that patient. Okay, I think we can continue here for an extra hour, but we have to close now the session. And for that, I will hand over to Dr. Freddie, so he can start wrapping this session and closing. You're muted.
Thank you all, of our speakers, and you, our audience, for joining and participating. We hope you found this session informative and useful, and we appreciate your engagement and hope you take away valuable insights from today's session. Thank to our digital learning manager and rest of the secretariat team for making this session possible. Take care and see you soon virtually or in Marrakech.
In Marrakech.
Yes, so I would like to invite you to continue with this topic next year in our World Congress of Anesthesia in Marrakech, 15th to 19th of April. So you're all invited, and meet Dr. Afak and rest of the team, that you can also ask right there personally your questions, and go ahead and more knowledge about this topic. We thank you for being here, for attending, and see you virtually in the next webinar, but also in person in Marrakech. See you there. Bye.
Thank you.
Thank you.
Bye-bye.
Bye-bye.
Have a nice day.
You all.
Have a nice night.
Hey, Freddie.